while we wait for people to join us? You are moderating, so for me, it's just to say hello. It's always very nice to see you all, and thank you for participating to this event, which is a very important event that we've now run for a few years. And it is always, as I was saying, a great opportunity to see we know what we do, but we want to share what we do in any case, because knowing the best practices is really another way of improving how we treat our patients and how we work. So this is really why this event is here, is really to share with those who are outside the ERN what we do, but also with us, so that we all always keep saying how we can do better. And so thank you very much. And now we leave the floor to Sara and Ilaria to moderate this event. Thank you very much.
Thank you. Ilaria first.
Thank you, Marta. Thank you, Sara. And mostly thanks to you that are here today. It's an important meeting, in my opinion, because if we want to harmonize the healthcare in Europe, it's even more important to harmonize the practices. So what's going well? And this is the reason why we are here today. So thank you very, very much. And please, Sara.
Thank you, Ilaria. Thank you to all of you joining. This is the third meeting that we are organizing on this, and we strongly believe on this, since, as Marta and Ilaria already said, the main mission of the ERN is to share the knowledge, but we would like also to share good practice, and this is why we organize this meeting. And in sharing good practice, we believe that in many cases, most of these things are also a kind of inspiration for many other people in different disease groups. So it is important for us to share and disseminate this. I give the floor now to the first presenter, Professor Smith, and she is presenting one of the most important milestone that we have in ReCONNET, the CPMS, created by the European Commission, and she is presenting an important good practice in her country, CPMS for national level clinical case discussion. Vanessa, the floor is yours.
Thank you so much, Sara and Ilaria. Can you see my screen? Dear colleagues, it's a pleasure to be here. I would like to present with Yves, who's a co-manager of CPMS. I'm the coordinator on behalf of the PISA coordination team, who is also beneficiary with us, on how may the clinical patient management system be integrated in the national healthcare system. We have discussed about this, Yves and I, and we are actually in Belgium doing this on 3 levels. And this is what I'll present. Yves will also present a 3rd level, and then some tips and tricks for all of you. So how can you integrate CPMS nationally? First of all, you may integrate this on micro level, and we will give an example of the Ghent University Hospital. You can integrate it on meso level. This means that as members, we can link to regional hospitals or cross-border to give advice. And you can also go one step further. Yves is the president-elect of the Belgian Society of Rheumatology, and he's integrating it structurally in Belgium through the working group on rare diseases. And that's the macro level, which we can all do as national hubs. So what is CPMS? It's a secure web-based IT platform that supports the work of European reference networks by enabling cross-border collaboration among healthcare professionals to discuss and manage rare complex diseases. The key functions are the following. You will have virtual case discussions. You have secure data sharing because it respects the privacy rules like GDPR. You have enhanced patient care because the patient doesn't have to travel, but the knowledge will travel, and you will see that in the meso level of integration on national level. You have a collaboration between healthcare providers across Europe. You have standardized information and standardized international ontology. And you have a user-friendly version, which can also be used on mobile phone. So let us start on how we are integrating this as National Hub in Belgium. Let us start with a micro level. We started as soon as the CPMS was launched by the Central Coordination Team in 2025 to use this at the Ghent University Hospital for our weekly multidisciplinary systemic sclerosis meeting. Here you can see us on a Friday, my two assistants being very tired because it's after 6 o'clock in the evening, our cardiologist and our pulmonologist. And how do we actually do that on a Friday evening? Well, Friday evening after our clinics of systemic sclerosis, I Google CPMS 2.0, I press on login, then I give my password and I say that I agree to be verified by a QR code. I get a QR code on my screen. I use my Eurologin, which is on my iPhone. I scan the QR code and immediately I get access to my own CPMS. Here you can see MDO systemic sclerosis. In fact, Yves Piet, who's the co-manager of the CPMS work package, enabled us to have weekly meetings, recurrent meetings, and the only thing I have to do on a Friday evening when I'm very tired is to click join. What happens when I join? Well, I'm sitting in the staff room of rheumatology. I see my cardiologist who's at home by that moment. I see my pulmonologist who's 1 mile away from me on the other side of the hospital, and we can discuss all our cases on systemic sclerosis multidisciplinary. In fact, we can open the patient's files through CPMS, but as I mentioned before, in a safe way. We started with one multidisciplinary team in the Ghent University Hospital. Now that it's up and running, we will have other multidisciplinary teams join with their CPMS to discuss cases. So far for the micro level. As National Hub, we also integrate CPMS on meso level. This means that when we have a colleague from a regional hospital, or a cross-border colleague from Denmark who wants to ask us a question, when they send us a mail or a WhatsApp, we ask them, please use CPMS because it's GDPR proof. And this is what you can see at the bottom of my screen. This is a colleague from Antwerp who had sent me a mail about a young lady who he had had questions about. I asked him, put it in the CPMS. He put it in the CPMS. The girl was anonymized to a nickname, Lily Captain. On Friday evening, I click Actions and I see what his question is. My colleague of Antwerp, in fact, asked a question about a young girl who had dyspepsia, Raynaud puffy fingers, a malar rash, but a negative ANA and negative lung function and HRCT, but 2 giants on capillary. He asked me, what should I do with this? Well, instead of sending this lady physically to the Ghent University Hospital, he plugged all information of this girl into the clinical patient management system, because he could not only ask his question here, but he also uploaded files. He uploaded the file of her malar rash, he uploaded the file of her Gotron papulus, he uploaded the file of her giants. So this enabled me to discuss locally at the ERN Expert Center with my colleagues and to give immediately, by a safe way, the CPMS back advice to my colleague in Antwerp. So this is how on meso level we use in Belgium the CPMS. Anytime a colleague contacts us, we ask them, please be so kind to upload a case in CPMS and we will give you safe advice and immediate advice through the CPMS. This brings me to the third level. The third level is the macro level. We want to structurally integrate CPMS in any communication in Belgium concerning rare diseases. And to this end, I would like Yves to speak, because Yves is our president-elect of the Belgian Society of Rheumatology and also chair of the working group within that society of rheumatology. And through this way, he's trying on macro level to use CPMS also in Belgium. Yves, could you please comment?
Thank you, Vanessa. There also you have seen now that how Vanessa integrated CPMS really in the daily routine of care at the Ghent University. But now we are, as a next step, we are trying to do that also on a national level. WeCare is this stands for the Weekly Complex and Rare Disease Exchange platform. Is a platform that is somewhat yeah, similar to CPMS. There are a few differences. This is a platform that is for rheumatologists to discuss. Also, we call it the hot burning questions, not really the in-depth, deep and long discussions, but the short burning questions. And every rheumatologist can upload a case. And then every 2 weeks, we discuss it with a panel of experts. And here you can see the core of that panel, and that contains participants from 5 or 6 universities in Belgium. And that is something that we now do on Teams, which we know is not the most secure tool platform to use. And after the experience that we have now on the micro and the meso level, we will now in the months, the first months of the new year, we will integrate the WeCare platform that is low threshold between peers. We will integrate it in the CPMS. So we combine the low threshold of the WeCare with the GDPR safe and approve platform. That is planned for the first weeks of 2026. We are already working on the next stage also, and also in January we will have or there is already a meeting planned with the French Society, with the French Network of Rare Diseases, where we will try to do the same thing. They also have an online platform to discuss difficult cases, and together with Professor Ashula, we have already made the first plans to roll it out also on CPMS. So that are a few examples on how we will integrate existing platforms and existing tools in the CPMS system. And then maybe for the few minutes that are left, I will just very briefly touch some common pitfalls that are very easy to overcome, but that can be a bit making the life difficult when you are starting with CPMS. Next slide, please, Vanessa. The first, and then Vanessa already alluded to this, you need first to have an EU account. You have to create a EU account. It is the same account that you use for other applications in ERN, and also the same account that was also used in CPMS in the first version of CPMS, so you can use the same one. But if in case you don't have any account, you have to create it. And you can find the link to create a new account on the CPMS 2.0 link. The same website that Vanessa already showed. Next slide, please. Step 2 is the link between your mobile phone, mobile device, and your account. Because you need the two-factor authentication, you have to link the mobile device to your account, and this you have to. Therefore, you have to perform several steps. That can be a bit difficult if you're not too much ICT literated. Eva de Grauwe, who is our other CPMS manager, has made an excellent tutorial that you can find. It takes only 5 minutes to watch, and step by step she guides you through the installation of the two-factor authentication. You can find the link and the website, the webinar on the website, the ERN website. Next, if you encounter difficulties with this, you may also always contact me directly or via Vanessa. Next slide, please. And then as a third and last step before you can start to begin working with CPMS, after you have EU approval, after you have the two-factor authentication, you need to request access to the CPMS, to your ERN, to ReCONNET. That's a very easy one, and you will have approval within 24 hours as a maximum. And then you enter CPMS, and then you can start. I won't go in detail on the user CPMS, but only touch a few pitfalls. Next slide, please, Vanessa. It's very important for purposes of archiving and also for registration and also for monitoring that after you have discussed a case that you close the case. Whenever you should have additional questions afterwards, you can always reopen the case. But after the case is discussed, please close the discussion. And then some two items that we encountered in clinical practice. Sometimes when you have forgotten your username, you request a new username, and it is possible that you have different usernames and different accounts, and that can make things difficult when you send an invitation for a CPMS meeting that it goes to the wrong accounts. And then maybe to finalize, this is an issue that we have encountered also in the Ghent University Hospital, that there can be problems with the local firewall from your institution. So it happens that you start CPMS and that you see an error for your audio or video tools. This is a firewall issue that is local to your, and your ICT can manage that. There's also a manual for the ICT in case they cannot solve the problem. We can send you a manual to help them. And then again, I told it before, whenever you have a problem, do not hesitate to contact Vanessa, me, or Eva. And in case it's necessary, we will be very happy to invite to have a short meeting, a live meeting with you to help you further. Thank you very much.
Thank you so much. So in a short nutshell, try to use it, all members in your own hospitals, in any multidisciplinary team, not only the rheumatology multidisciplinary teams. Try to encourage your colleagues from regional hospitals or cross-border to contact you through CPMS, and try, such as Yves and Erika Schula, to integrate it in your national systems. Thank you so much for your attention.
Thank you so much.
Thank you, Vanessa. Thank you, Yves. Are there any questions?
One comment probably from Marta.
Only just to say that thank you. This is a great example on how we should all be using the CPMS. And I think that the example means that it is possible to use the CPMS and to extend the use to colleagues who are outside the ERN. And it is possible really to do what the ERN tell us to do. The information travels, not the patient. This is also very important if we go and if we think about the need to integrate the ERN with the Jardin, for example, because the CPMS is really the way to go. I think it's a very important measure. So I would like really to highlight the importance of what the Ghent group has done in this type of integration, because they are really a model for everyone and is the model that should be used. And it is very, very important. And I really believe that this is one best practice of ERN ReCONNET. I'm not really sure that other ERNs have really been able to integrate the use of the CPMS in this way. I mean, many other ERNs are using have been using the CPMS even more than we have done in ReCONNET. Maybe they discussed clinical cases, but I'm not really sure that this level of integration is there for all the ERNs. And I think that this is what we need to do. So again, thank you very much and congratulations. It's a big work that has been done here. And now we follow this best practice, actually, so to say. So thank you very much.
Yeah, I couldn't agree more, Marta. And also because the platforms are the future for the European healthcare, and showing that the CPMS that has been created for other purposes can be used for the integration is really incredible. And it's free because it is made available by the European Commission, is complete, extensive. Maybe, I don't know, Vanessa, is not interoperable with other platforms at the moment.
It is. We are using it with the local patient platform, so we can pop up HRCT, etc., etc. So it is interoperable within your hospital, even though it takes some glitches. But Yves and Eva have been fully supportive. We have a technical help desk from the European Commission. So if you take the time to patiently install it and to have some pitfalls, as Yves nicely showed, but once you have everything up and running, it's a very easy system.
Fantastic. And I am sure that as we are at the version 2.0, we will have soon the version 3.0, and all these pitfalls will be overcome. Okay, so Matthias, please.
If there's a place to discuss, I would ask you three questions. You need an informed consent of every patient. The second
In fact, you need it
question,
signed in your office, printed in your office for if there is monitoring. I know that there has been comments on that, and people are still discussing about that. But up until this very moment, you should have informed consents which are signed in your office.
okay. And the second point, everyone who's using it needs a confirmation by his ethical and data protection system. So every hospital or every outside
Yes.
user too.
Diana and the PISA team, for that reason, has already contacted the DPOs of every member and has told them that the European Commission has checked the data protection assessment already. That's something the local DPO must decide. That's not something that will be decided by the European Commission or by our network. But the DPOs of each university, of each member of ReCONNET have been contacted already on that point. Diana, please correct me if I'm not right.
Yes, basically the European Commission distributed the hospitals of all the ERNs, and each ERN contacted the hospitals that were located to their ERN. So every DPO of every member of the ERNs, all the 24 networks were contacted. And in fact, Eva sent all information to all of you, but there are information sent also from us. So if you didn't receive it, we can send it over to you. However, take into account that is not a unit center activity. This is a hospital center activity. So this exercise has to be done once. But even if you are a member of many ERNs, this assessment has to be completed only once. So probably they will be contacted by centrally, not by each individual ERN you're a member of, but just once.
My question is, if someone else outside, so if you go on the macro level and someone else outside the ERN is using it, and then the question is also, this hospital also needs to be informed about the process. How are you doing that in Belgium? You have other hospitals in that are not member in ERN.
I'm a very pragmatic clinician, so when my colleague of Antwerp WhatsApped me, I said just contact Yves and get into the system. I'm a Belgian. I didn't go as far as asking him, did you contact your DPO to see if he checked the DPI which has been approved by European Commission? I didn't do that. I'm pragmatic and I only have 24 hours in my day. But
I'm fine. I'm just questioning. So you have a gray zone there. That's okay.
That's a gray zone. I fully agree with that.
And we have to say
my
that
third
the
question is,
assessment was done by the European Commission. It was considered compliant. So we are very safe on that side. So if it is a very local or
Diana, if you are fine, it's fine. But if the person who is using it should be fine, that's the point, you know?
Well, the European Commission stated that they are fine, that they have checked it, but that of course they cannot decide for local governments.
Yeah. Yep. Okay. And my third question is, if I understand, should read correctly, you use a different system for your macro level, not CPMS. Why?
At this very moment, yes, because we started it already a few years ago, but we will integrate it. So we will do everything on CPMS from normally we will have the tutorials, education in January, and in February we will start. But we will use CPMS, but we will use the meeting function of CPMS. So we will only have the national people that will use CPMS as a platform for our communication and as for our discussions.
Yeah,
It will be
Matthias,
the
the
same.
WeCare, sorry. Matthias, the WeCare was in fact meant for, we do have reference centers in Belgium, and we send all our patients to reference centers, but that doesn't stop a colleague from a regional hospital to have a hot burning question. So this WeCare platform existed already to reply to a hot burning question, any question. Should I do a capillaroscopy in this case? This is something that can be asked on WeCare. Even that platform now will communicate from now on through CPMS, but we had to start on micro level and meso level to see where the glitches are before we ask all our rheumatologists to, when they want to ask any question, to use the CPMS.
To be honest, Vanessa, I like what you are doing, so no issue. Question is for me, can I copy it best to Germany? You know, that's
step by step. Start in your local hospital with your multidisciplinary units. Ask Yves and Eva to help you. Contact the technical desk of Europe if there's issue. And when your local multidisciplinary team is working, you can start working on meso level when somebody contacts you from outside, and then you can bring it on whole German level.
Thank you.
Thank you. Sorry if I interrupt you, but we have to move to the other presentation. And of course, it was very interesting for people from ReCONNET, but we guess also for people outside joining today. And for them, probably it will be very inspiration for this. So thank you again, Yves and Vanessa. I give the floor to Ilaria for introducing the next.
Yes, it's my pleasure to introduce Gianluca Moroncini from Ancona. He will present his best practice called Personalized Integrative Care for Immune-Mediated Rare Diseases. Gianluca?
Thank you very much, Ilaria, for your introduction, and good afternoon, everybody. I've tried to share my PowerPoint here. Okay, let me check. There we go. Hopefully you will see it soon. Now, hopefully it's uploading. No, it's not this one. Okay, let me check here. Here we go. Okay, now we should be all seeing my first slide. So again, thank you for this initiative and for letting me present some of our best practices. At least I think this is the best practice of my group that could be translated also to other centers, and I'm sure other centers are already performing some integrative care for our patients. So I will speak a little bit about what we have been doing in the past years, and I think this has much to do with the mission of ERN ReCONNET. Indeed, I belong to this group now since some years, and I'm very much involved in the scleroderma patient partnership working group. So I will present general our activities, and then I will make a focus on our activity together with our patients affected by systemic sclerosis. So, as you all know, health is not only what we doctors can evaluate from our personal point of view, but it's something that has much to do with everyday life, a general concept which also has to do with the social life of our patients, the personal life of our patients. And so it's something that goes much beyond, what we doctors can see in our patients. And integrated medicine represents a multidisciplinary, multi-professional approach that combines conventional and complementary therapies in a personalized, patient-centered framework. As you can see here, I wrote down some of the main tasks of the integrative medicine approach. So nutrition and diet, integration and phytotherapy, psychological support and counseling, shiatsu and other massage techniques, drugs and conventional medicine as, the main point of integration of these other activities, mindfulness and meditation, lifestyle, Chinese traditional medicine, osteopathy, yoga, and other mind-body practices. The main goals of all this approach is to reduce stress, enhance overall well-being, relieve chronic pain, boost body and energy awareness, improve emotional and relational health, provide a supportive environment for deep relaxation, manage agitation, panic, and mood swings, enhance sleep quality, promote anti-inflammatory preventive nutrition, and alleviate gastrointestinal symptoms. So we have dissected a little bit the aims and the functions of these different integrative medicine approaches. For example, for nutrition, with many scientific evidence upon it, we want to prevent immune-mediated and cardiocerebrovascular disease progression. We want to reduce symptoms in chronic conditions, and we can, improve the management of inflammation and promote patient autonomy in dietary choices. Integration and phytotherapy may help gastrointestinal regulation, better sleep quality, reduce chronic fatigue, joint pain relief, and the correction of vitamin and mineral deficiencies. And also, we may impact on dyslipidemia and glucose intolerance, cardiovascular risk, gastrointestinal reflux disease, bowel or digestive disorders, the dry syndrome, which is typical of many connective tissue diseases, food intolerances, and allergies. The osteopathy can help the musculoskeletal function of our patients, promoting a good balance, supporting the body's natural ability to heal. And we can improve mobility and enhance the overall well-being. The shatsu, a traditional Japanese therapy using finger, hand, elbow, and foot pressure on vital points, can relieve muscle tension, reduce joint pain, and improve mobility. And the yoga that you all know, can promote physical and mental well-being and can improve, breathing, flexibility, strength, posture, and balance. Again, the psychological support is very important for many of our patients who undergo, very heavy psychological distress, anxiety, depression sometimes, and the psychological support can promote self-awareness and communication skills with the patients, among patients, patient doctor, patient and personal caregiver. And so this is very much important for a better stress management and also even the acceptance of the illness itself. The mindfulness, important, very important because, can work on the self-esteem of our patients, can enhance the concentration, the focus, the attention, and can help also managing stress, anxiety, and regulating emotions. We can now apply also Tuina, which is a traditional Chinese medicine approach that can include acupuncture, phytotherapy, dietetics, and medical gymnastics also. Tuina is indicated for our patient, and we are now offering it to many of them. Which is the clinical experience in our center? Currently, 87 patients affected by the diseases that you can see here in this list are under care in our integrative medicine outpatient service. It's something that we have established in 21, and we are now going on. Of course, it's all self-sponsored, so we don't have any support from our hospital. We don't have any support from our university. I can, of course, offer payment to the professional that are helping me with these practices, deriving the funds from the clinical trial. And so we have, you see, many patients, mainly affected by systemic sclerosis, 38 patients, who can receive nutrition, integration of lifestyle, mindfulness, psychological support, shiatsu, tuina, and yoga. So this is the casuistic that we have managed recently. These are our 38 patients who have completed the treatment. So you see the number 20 of these 38 patients received a personalized nutrition and integration approach. 5 patients with the Shatsu were treated, 2 patients with the Twina, 14 with psychological support, 3 participated into the mindfulness sessions, and 7 of them participated into the yoga class. We have so far evaluated the impact of this approach with these 38 patients using the regular SF-36 questionnaires, pre-treatment and post-treatment. So you know this short form questionnaire is evaluating several items for a total of 36 items belonging to these different domains: the physical activities, the physical limitations, the physical pain, the general health, the vitality, social activities, emotional limitation, mental health. And for each of them, of course, there is a scale going from the worst number, which is 0, and to the best number, which is 100. So it's a numerical scale. And so you can see that comparing the pre-treatment median values with the post-treatment median values, we achieved in some cases a nice p-value of increase in this SF-36 questionnaire, mainly in the physical activities, the physical limitations, the social activities, and the mental health. And if you can see here the radar schematic indicating this increase, you can see that for most of these activities, we achieved a certain kind of improvement, which is sort of encouraging to keep going with this approach. Here you can see in the summary of the physical and the mental component scores, you can see that comparing the pre-treatment and the post-treatment patient self-assessment, we have, an improve both for the physical and the mental component scores. Of course, now we are trying to achieve better measurement of the impact of this integrative approach on the disease itself, not only on what is reported by the patients. So to conclude, to summarize, integrating Western medicine and complementary treatments offers a comprehensive approach to modern health challenges with carefully selected therapies that respect individual needs and uniqueness. And I'm very glad to share it with you. I hope this can be a shared practice among our ERN ReCONNET centers. And I thank you for your attention. As you can see here, these are the numbers of my collaborators. And we have an email address which is dedicated especially to our connective tissue diseases patients, and that they can use, in order to manifestate their interest to receive this approach. And we use this email to follow, every day our patients through this new integrative medicine approach. Thank you again for your attention.
Thank you, Gianluca. Very interesting, very interdisciplinary. Thank you. It's very much appreciated. I'm talking on behalf of patients.
I'll try to interrupt okay, here we go.
Okay. And is there any questions? No?
I would just, if I may, compliment for this, since it's very, very interesting. And
thank you, Sarah.
Just a comment question. What do you suggest from the practical point of view for the other center who, of course, will take inspiration about this and will try maybe to build something similar to this? How would you suggest to start?
First, Sarah, I would like again to reinforce the observation that these practices are seen, are considered to be very useful from the patient themselves. So, in our center, there is a service that we do every Monday, and then, of course, we organize and set up these programs. This is very much welcome from the patients themselves. They are the first ones encouraging us to go ahead, and they're very worried that we don't receive funding for these activities because they really like them. You might consider also a level of, patients perceive it as a further level of care besides the regular activity that we all perform in our centers, the therapies, the follow-up visits, the clinical examination, the CT scan, the spirometry. So it's something more. So it's something that enriches even more, their path towards a better care. So I think there is also an important psychological component of, the patients feeling to be the center of the attention of a group of doctors and also health professionals, because here we have, many health professionals being involved. That's another important aspect of this activity, because there is a constant dialogue between doctors and HP, and even a selection of patients. Because I must say that the patients that undergo this service of my clinic, of my center, are the worst ones. So the ones that, despite our best therapies, multi-level, biological treatment, non-biological treatment conventions, are the ones that keep complaining about their health status. So people that, although you achieve a perfect control of the inflammation, even a perfect, control of the clinimetric testing, they keep saying, that they are suffering, that they're not feeling well. So really, it's an integrative approach. So from a certain point of view, I realized, by conducting this practice now for the past 3-4 years, that, the worst patients, can have a very important benefit out of this practice. So what is my recommendation besides this general observation is that we can try. And of course, I'm ready to share this practice among center. We can start, if the other centers have the possibility of hiring or paying, even for a short time period, some of these professionals, we can start, trying to share this practice, and I have no problem in indicating to you, let's say, a skill or how to proceed, for example, for the counseling or for the nutrition. We might even, try to push some of these practices as a multi-center intervention that we can try to standardize as much as possible. Maybe, not all the items that I present, but we can focus on some aspects that these colleagues here can identify as the most feasible, and try to then compare even the response from different centers and see if it's something that can be used also to ask fundings to the institutions.
The main thing
I've tried several times, of course, to ask money both to my hospital and to my region. And of course, there are never resources for these tasks. So as I said, it's self-sponsored, and I get the money to pay these excellent health practitioners, from the clinical trials. What I get in the hospital from the clinical trials, I use some of this money to pay these people, and the patient, are very happy for that.
Thank you, thank you. I see hand raised from Marta.
So congratulations, Gianluca, because this is really an example of an holistic approach in the care of our patients. And this is really holistic because it goes really beyond what is the traditional care. I mean, we do have a nutritionist in Pisa, but we don't do other activities. We had a physiotherapist, but not this. So I think it's very important. Actually, you already gave the answer to my question, because I was wondering how you were able to manage and integrate this in the clinical activity. And you also have spaces, I guess, in your clinic, because for me it would be a big problem to find a place where to do where I could do this activity, because we don't have enough. I mean, we have a very big clinic here, but it's always full of assessments. So I think we will need to see your model, because everyone, I guess, in this virtual room, would want to do this, and I'm pretty sure that our patients would want to find this. But I have many.
We dedicated, when I became a director of the clinic in March 21, I identified the Monday ambulatory
But you do have a room to do this? I don't.
Mainly based on this activity.
Yeah.
And then we have another room in the afternoon that we also use for this activity.
Yeah.
And so we were able to use these spaces. Of course, it was not seen so well at the beginning because, of course, our general managers at the hospitals, they want us to reduce, the patients' list. So they mainly want that the spaces are used, for regular activities. This is something really unconventional for our standards. But, we were able to get these spaces for us. And I was also lucky because I had, some of my collaborators that really liked this approach. And indeed, my main collaborators, Dr. Antonella Festa, she's the one, who promoted this approach very much. Of course, I gave her support. And so we have also some resident fellows that are really, enjoying this activity very much. And then, we started like this, like a preliminary experiment. And then it became something more. And it would be very good to have it, also, as
Yes. I also have another question for you.
Yeah.
Were patients' associations involved somehow? Were you able to involve patients' association, for example?
I mean, if you think of involvement as their awareness that we are doing this, yes. So, for example, we do this, when we organize, the national events, let's say the GILS, the Italian Group Against Scleroderma, when we did the national event here in Ancona on April, of course, we dedicated a session to this. And as you know, it's always the most appreciated by patients, much more than our clinical trials and so on. And also for the lupus patients, we also did that, although lupus is not covered directly by ReCONNET, but of course is very close to our interest. So yes, patients associations were involved as information. I didn't ask money to them. This is something that I didn't do as a further level of involvement. But also, this might be, an opportunity. The Patients Association can, spend some of their, few resources for this point. I don't know what Ilaria thinks. We might ask. But for sure, they are involved, meaning that they were informed that we were doing this kind of activity and they like it. We published something on the Giornalino GILS here in Italy with a magazine of the Italian Group Against Scleroderma, and we also did that also for the Lupus ODV Italia for the Systemic Lupus Erythematosus Journal. Yes, we published some of this preliminary report just to let them know that we were trying to integrate our normal activity with this special approach.
You know that in this way you will create a revolution among patients because they will ask why in my hospital there is not such an activity.
Yeah, that's a possibility, Ilaria. So yes, we also must be always very cautious not to.
No, but I was joking.
No, but you're right. I always avoided to go on journals on publish too much this stuff, not to generate too much and too many expectations, also among other patients and other centers. So I try to keep it, always very much confined to our center and not to, make a big publication of these approaches, because as you said, then once I spoke about it at a local conference, and the patients immediately start up asking, why not here, but who's paying for that? How is it possible to have access to these practices? And of course, I always make the point that is, for now, unfortunately, limited exclusively to the patients of our center, because we can manage those small numbers. Considering market region in Italy, here we have approximately 750 patients affected by systemic sclerosis, and you've seen the numbers, is 38 patients who are, among are in the group of our 350 patients that we are actively following up. As I said, it's a selection of patients who, according to our clinical evaluation, we think they might benefit the most out of these practices. So we don't have the energy and the money and the spaces to, of course, provide this approach to all of our patients. Yeah.
Okay, thank you, Gianluca. Thank you for this very enthusiastic presentation.
Thank
And
you.
we can move to the other speaker, and I have to say it's an honor for me to introduce one of the super experts on this topic, capillaroscopy, Professor Cutolo, with the presentation, the evaluation of microcirculatory status, in CTDs by capillaroscopy. Professor Cutolo, the floor is yours.
Thank you, Sarah. Thank you for the invitation to this important meeting that is something that should share the good practice. We must remember that we have, of course, also patients listening. So I try to, even if some of us is a daily practice, what I show for others is not daily practice. So the title, as you mentioned, is generally the evaluation of the microcirculation in connective tissue disease, including rare. It's clear that the connective tissue disease that we consider is a limited number, but some of them are really important. Rare, relatively rare, but important. And so it's clear that what we will discuss is reflect what we can observe also in other conditions. What is similar for all the condition is the inflammatory reactions. In any part of the disease, at the beginning, during, as a comorbidity, the patient meet the inflammation. And the inflammation, it's a pillar of this problematic way to co-share the life, because inflammation means symptoms, and symptoms means the majority driven by the microcirculatory status. Tenorized pain, loss of function, and so on. But the involvement of the microcirculation is the most important aspect. And the damage in some of this disease of the microcirculations forever or for a long time, sometimes irreversible. So it's clear also that in normal condition, capillaries are the last part of the microcirculation that bring, but also pick up substance, information, and bring cells. And as if in a normal condition, the array of the microcirculation is well distributed in order to exert this important control of the function of tissues, organ, and so on, it's also true that once start the hurricane inside the vessels with all the cells that comes, leaves, meet each other, and start to produce mediators of inflammation, the microcirculation, it's become absolutely one of the most important can I say, killer of the tissue. You can see here the cells that move from the capillaries in the tissue, the blue dots, and here you have any kind of cell, neutrophils, lymphocytes, monocytes, and they start to work to meet each other, to produce locally many of the substances that will create the clinical symptoms of the inflammation, the pain, the major problem for the patient, but also in chronic condition, the loss of function. And it's clear that at that point, the microcirculation, the capillaries are totally altered, and they cannot exert their normal activities. They cannot, because this is a field of a terrible battle that is start. So, the possibility to observe what happened at the level of microcirculation in a very safe and non-invasive system. For example, here we can say systemic sclerosis, because it's one of the conditions where much easily, and we know also that the damage of the microvessel is the beginning of the story, is the use of the capillaroscopy. You can use any kind of device, for the first level, even at USB, it's practical to distinguish the early signals. Of course, the video capillaroscope is the best way connected with the software and to collect and to evaluate, quantify the damage. So, but what is important is the evaluation from the beginning and during the progression, what is going on, because the condition of the microvessels is associated with the condition, the tissues, in this case with the progression of fibrosis. Less vessels, more fibrosis. And this is important point because everything starts with Raynaud. And so to distinguish the primary from the secondary Raynaud, the only way we have to have something objective is the capillaroscopy that detect the early irreversible damage of the microvessel. The systemic sclerosis starts from the vessel, from the immune inflammatory reaction around the vessel. So the possibility to make a very early distinction between primary and secondary is the very early, also in some cases, diagnosis of systemic sclerosis and other connective tissue disease, as you can detect the progression. And this is also associated with the analysis, the functional analysis of the peripheral blood flow with the different system of laser Doppler. We use the laser Doppler with the LASCA system that analyzes each single red blood cell that passes through the vessel, the microvessel, and you can see on the right, for example, a completely normal condition and a good number of capillaries on the left, reduce the number of capillaries, increase fibrosis, and reduce blood flow, and very intensive Raynaud, of course. So you can have a morphological capillaroscopy and functional analysis, and if you combine both, you have a very important quantifiable, because both can give a number, so important for the follow-up of the patient and also for the analysis of the effects of possible treatment, local treatment as vasodilators, but also treatment on the mechanism of progression of this damage. So the naval capillaroscopy lets you to follow the progression of the disease, and we well know, we will see is associated with the clinical, progressive clinical involvement and the compromission of organ and tissues. So in few words, we have a first part that capillaroscopy may detect the preclinical, we can say preclinical, just Raynaud, but you see the very early changes, the very early dilation over, but under the classical giant, but it's a progression of dilation. That means that progressively the capillaries are damaged. And like a baby giant, they will grow as an adult giant and finally will appear. But when they appear is the time of the clinical complication, when you have the real involvement of the microcirculation and the tissue with progressive fibrosis. It's clear that you enter in the clinical aspect of the disease. So it's really important to do this follow-up every 6 months, for example, to evaluate and quantify the number of capillaries, less capillaries. More you can also predict the involvement, for example, of the lung involvement. There are now several important research shown, but also for digital ulcers. You can predict the appearance of new digital ulcers, and you can treat, and several papers show this possibility to predict. So the evaluation of the microcirculation, as I mentioned, is not just related, of course, to systemic sclerosis. The microcirculation works and is affected in several other connective tissue diseases. For example, we can say that in the dermatomyositis, in myositis, and in overlap syndromes, this so-called scleroderma pattern that shows the different aspect of the involvement, the dilation, angiogenesis, microhemorrhages, collapse, loss of capillaries. And you can see here very nice microhemorrhages, and the capillary is collapsing, the giant is collapsing. This is very, very clear that at that time there is a terrible hurricanes in the tissues. And we can see just with the nail fall, but this is happening also in the gastrointestinal system or in the muscles. And even in a much more complex disease like the antiphospholipid syndrome that is characterized by thrombosis, the microthrombi, so parallels, the comb-like distribution, especially in association with IgM, IgG, anticardiolipin, all of these data are published, of course, is a part of the analysis of microcirculation in antiphospholipid syndromes. There are other conditions that not strictly autoimmune in the sense of adaptive immunity, but innate immunity involvement, like psoriasis and psoriatic arthritis. Here, the easy capillaroscopy, the skin, can detect per centimeter square the number of angiogenetic vessels and give you even the border of the lesion. You can see, you combine the capillaroscopy with the LASCA and with the morphologic aspect in the first row, and you can see the lesion of the skin, the vasodilation related to the inflammation of the skin, and on the right you see the angiogenesis that is inducing the vasodilation, of course, and the increased blood vessels movement. And you can see also in the second row. So other include lupus erythematosus and Sjogren and so on, where we have a lot of recent investigation. For ReCONNET, we prepare this infograph for the patient, especially explain what is capillaroscopy, just to make very friendly this analysis, not be worried that this should be a damage to do it, just a camera with a micro camera and light. And also we produce for ReCONNET several webinars, one of the last by Shasha on microvascular involvement or the transition from primary to secondary, or another microcirculation lupus, and so on. So ReCONNET is involved in distributing information also in such way to inform doctors and patients. This study was a large study published in Arthritis Rheumatism, over the 600 patients, and show how it's important, it's possible to predict and to let know if new ulcer will appear in the patient based on 120 different parameters that you can evaluate with the capillaroscopy. And this is a 12-year study following regularly every 6 months the patient with systemic sclerosis for 12 years. And it's possible to see how the involvement of the organ and tissues was increasing over the time. So less capillaries, in few words, more fibrosis, more tissue and organ involved. That was validated by a multi-center study published 3 years ago. So in conclusion, we can say that more and more different patterns have been now identified, reflecting the intensity of the microcirculation and the status of the immune inflammatory reaction in a very, of course, safe way, and also collecting the picture and comparing over the time the pictures quantization for this. And important also, we have data on the treatment effects, at least in systemic sclerosis. In the last published paper, that was a subgroup of patients during the census studies, we found in 120 patients very important data concerning the capillaroscopy in patients that improved their lung function treated with tyrosine kinase inhibitors. So this is the final message that capillaroscopy, in special nail-fold capillaroscopy, is something that rheumatologists, they know, but the patients and colleagues from other specialties should consider when they approach patient with a suspect or full over disease in connective tissue. Thank you.
Thank you. Thank you very much, Maurizio. I could say very interesting, but honestly, I I hardly understood a few things. And is there any questions from the attendees? So you've been very clear.
Probably, if I may, one of the main inspiration also for people not using routinely capillaroscopy could be to think also about the use in the different CTDs, since we know very well the use in systemic sclerosis and in mixed connective tissue disease, but it would be really useful also in other CTDs, and
Yes.
there are a lot of growing data on this. So
I can tell you, for example, in 2013, Ilaria, when the ECR Euler introduced capillaroscopies and the systemic sclerosis guideline, the sensitivity and specificity from 0.7 moved to 0.9. So you can imagine that this paper is published in Arthritis and Other Rheumatic Diseases 2013. I knew everyone should move to there and see how for the patient to add capillaroscopy or for suspicious patient is so important to improve the specificity and make much easier and safe the diagnosis.
And is non-invasive, Maurizio, which is important for us. Matthias.
Yeah, hi. Thank you, Maurizio, for this great talk and the overview. My question is, do you have any negative or positive predictive values for pulmonary hypertension?
Yes, there are predictive. These are the first study from Holland was done in pulmonary arterial hypertension and comparing patient with systemic sclerosis without and with pulmonary arterial hypertension and with idiopathic pulmonary hypertension. And it was very interesting to see that the capillaroscopy in patient with pulmonary systemic sclerosis with pulmonary hypertension, the prediction was much higher and the damage was much higher. So to the damage linked to the systemic sclerosis, the progression of the damage to the lung and the appearance of pulmonary was correlated to the reduction of the microvasculature and increase of fibrosis. And this was one of the most important studies. And many studies are evident. I think there are at least 12 papers.
But my question is in respect to, would be capillaroscopy enough to screen for pulmonary hypertension, or you still have to do more?
Oh, you asked more? What? Sorry?
So is that enough for screening pulmonary hypertension? That's a question. Or you still need an echo?
Oh, no, you need also the echo for other issues, of course.
It's not sensitive enough. Sorry, the question.
Yeah.
Okay.
Yeah, absolutely. And there's a second step that may be ILD. And here is even more evident because ILD is a clear, evident fibrosis. So fibrosis means reduction of the vessels. And here is even more evident, this correlation with the reduction of the function of the lungs and associated problem related to this dysfunction of the lung and microcirculation, micro.
Thank you.
Thank you. There is also a question from the audience. Would it be effective to use it for eczema?
For?
Eczema.
Eczema? Well, the dermatologists use, we don't use, of course, because it's not our field. But what we saw is that when you have a lesion, psoriatic lesion, sometimes you cannot really be sure how large is the real damage of the skin. If you combine the the capillaroscopy on the skin and even the LASCA if you can, you really can see if over the time the lesion is growing deeply on the tissue, because in psoriasis there is a big angiogenesis that support the lesion on the skin. And when you use, for example, IL-17 inhibitors, you see that the lesion regress. There is a regression of the cutaneous lesion, either with a skin capillaroscopy, either with any Doppler system. We use the LASCA.
Thank you. I do not see other questions from the audience.
No, me neither. So we can go on with the next presentation, and we go back to talking about the integration. So it's my pleasure to introduce Angela Tincani and her presentation, Integration and European Reference Networks, a model for improved rare disease care. Angela, the floor is yours.
Thank you. Good afternoon, everybody, and I hope you can see my presentation. And thank you for letting me share this small experience that we are doing. Let's start from National Health Service in Italy.
Sorry, Angela.
We do not see your slide, Sharon.
So, I try again.
Now it's loading. Yes.
Now, yes, so I can put in presentation.
Not in presentation mode, but
Can you
no.
see now?
Yes, it was better before. This is not presentation mode.
Okay, so I go back. Is
Yeah.
better like this?
It's bigger this way.
I see, but
Down, down, down with the mouse. On the right, the first icon, right, not that one, the other first, so it's the last.
yes, but I lost the slides.
Ah,
I have your face.
oh, mamma mia.
So
If you want to send us the slides, we can share.
No. Now you see?
Click.
You see?
Yes.
As before. Okay, no.
No. I don't know what happened. So,
But this way is good.
this way is good? No,
No,
I don't know.
no, you are recording now. You have to go back to the menu of the program, yes, and
Here.
and probably go to presentazione dall'inizio.
Yes, presentazione is here.
Dall'inizio. Oh, no, okay.
Okay. Is okay?
I think that can be okay.
Yeah.
Okay. So I am sorry. I was before telling you that most of the activities of the National Health Service are delivered by the hospital in Italy. And here is a list of the big hospital in Italy. And as you can, and it is underlined in red, the hospital where I work. That is, of course, a very big hospital. So speaking of integration, we have also to take into consideration where are we living. The hospital where I work have more than 7,000 employees, 62 medical wards with more than 1,500 beds, and it delivers 5 million services for outpatient each year. So it's very big. And what about rare disease? Well, rare disease, the hospital is a referral center for 282 rare disease codes, and 40 units are involved in these jobs, in this job, with 167 specialists that are certifying doctors for rare disease. And if you go to the administrative data for rare disease, we have 14,000 patients with R code that are assisted in our hospital. We also have a rare disease center with 1 MD and 2 healthcare assistants. So how is working all this big machine for rare disease? Well, this is a slide that I had from the administration. So starting from the community care, general practitioner, family pediatrician, or even patient association can advise patient who needs information and send him to rare disease center, to contact the rare disease center. And rare disease center can deliver information to patient and their family and help and assist to reach the referral center and the specialized clinic for his or her disease. Then, of course, there is the hospital. The hospital does what every hospital does, so it treats inpatient, day hospital patient. He has a dedicated outpatient clinic and also personalized, should have personalized patient multidisciplinary pathway that could be, that should be managed by case manager that are a healthcare assistant, and also in the hospital is possible to have multidisciplinary consultation. So the patient is diagnosed and treated in the acute phase. When the patient is stabilized, again, through the rare disease center, he can be asked if his adventure in the hospital was good by questionnaire. He can contact through the rare disease center if he has not done it before, patient association. He can have information about the existence of possible community-based services and how to go to these services. And also he can have information, the patient can have information about the regional national rare disease organization that is a registry not only for disease but also for doctors. So if the patient need to move or something else, knows who can contact. And then through the rare disease center, the patient can also assess back to community care in the territory. So here he can assess to, for example, physiotherapy, or he can have nurses, specialized nurses, or he can have also telemedicine service consultation with the hub center. And in the community care, there are also specialist outpatient clinic and social services and so forth. So this is the ideal pathway of the patient. I am not saying that it's always like this, but the effort of the national health system is to do this pathway for rare disease patient. Now in our hospital also have the seat of 9 ERNs, 3 since 2017, and among these also ReCONNET, and the other in the second call. So this is a great enrichment for the hospital, of course. But the problem is, can really having ERN make a breakthrough in rare disease care? Well, theoretically, yes, because ERN means a network of center of excellence, means that it's possible to share state-of-the-art knowledge, define practical strategies like red flags, for example, to have the opportunity of international consultation. We heard before of CPMS. ERN can give the optimization of the patient pathway, and also can have the precious expert-patient collaboration that can, of course, give a value, an important value to the team. In addition, also European registries can be built, and their importance is evident. And also, finally, it's possible through ERNs go in another place and assist to their work and see how they work and take back what we think important for our center. So this is very important. And final aim of ERNs is to ensure that every patient receives the same high standard treatment across Europe without the need of cross-border travel. But you see, also the final aim of National Health Service is similar in some way, because the aim is to ensure patients to receive the best possible care at their local referral center and through the community care service, and very importantly, the cost for patients are covered by National Health System. In addition, patient association also interact with National Health System at different level and with all the stakeholders. So these two elements should have only advantage to interact by themselves. But do you think that all the people that work in my hospital knows that 9 ERN are based in the same hospital and that they can have many benefits interacting with them? Of course, the answer is no. But we are ERN, we are member of an ERN, and we need to deliver education. Therefore, in the last 2 years, in 24 and 25, the 9 ERN of our hospital together managed to organize 2 meetings aiming to show their activity, to show themselves and their activity to the colleagues. But unfortunately, the attendance was very poor, really frustrating. So how to capture the interest of the people? Well, we thought that could be a way to include people. So we organized for 2026 3 ECM meetings of 3 hours each, one in February, one in June, one in October, open to all the ACP interested in rare disease in our and in other hospitals that are near to our hospital. The general program of the meeting that will be almost the same with different actors is first an introduction by the Rare Disease Center about their activities, problems, interaction, and so forth. Then the presentation of a pediatric ERN, because we have in our hospital also pediatric hospital and adult hospital. Our is a mixed place. So a pediatric ERN presentation followed by an adult ERN presentation. And then the presentation of a pediatric unit that is not involved in ERN, but is reference center for rare disease. And the same for adults, because we keep in mind that colleagues that are not in ERN simply because they didn't apply, not because they are unable to treat rare disease. This was said by Professor Mosca just 3 days ago, but is really truth. And finally, this meeting will end with a discussion that will be chaired, a half an hour discussion, that will be chaired by 3 colleagues of units of ERN or different units that are not involved in the previous presentation. So, will we work? I don't know, but at least we will try next year. But let's say that everybody has learned the advantage provided by ERNs. We need to keep in mind further consideration for ERN integration. Because all of us working in a referral center have a common duty, as common duty to treat rare disease. But if we work inside an ERN, we have all the advantage of networking, like update and effective care, and like global expertise. So we are not acting as a single person. We are not acting alone, but are part of an international network of experts that are dedicated to the specific disease we are treating. So this is really great. But there are also a current burden, because also to manage a patient with a rare disease is already more time consuming that compared to a standard patient care. But to work in a ERN demand extra effort, and this extra effort is sometimes done on the top of our normal work. So during the evening or during the weekend or so forth. So this is not feasible if we want a real integration, but I know that ERNs are working, trying to overcome this problem. So I just want to thank Marta, Diana, Sara, Maurizio Cutolo, the expert patient, and all the ReCONNET team, because they are doing a huge work and continue to do a huge work for much time. And I also want to thank all of you for listening to me. And sorry for the slides.
Thank you so much for this wonderful presentation. Are there comments? Yes, Marta.
I have to comment. You quoted me. So no, Angela, thank you, because this is indeed where we have to go and what we have to do. And these are the concepts that we need to bring, because the ERNs are there to be used by everyone and to be integrated. And I think this is an amazing model of integration that you have set up. It looks like everything is connected, also with the meeting we had 3 days ago at the Italian Society of Rheumatology meeting. And so it was just a comment. I think really we will circulate all this information so that these best practices can become best practices everywhere. So this is the only comment, is really very, very important. And thank you very much also for highlighting some issues that we may have, and this also is important. So great. It was just to thank you on this. It's really interesting how, I mean, it's nice that we think in the same way, isn't it? And we move with these steps in the same way, because it means that we are really aligned, and it's great. So thank you very much.
Thank you, Marta.
Thank you. Are there other comments or questions? If not, we can move to the next presentation. Dr. Sara Ferrigno from Tor Vergata. And the title of the presentation is From Effective Communication to Good Practice, a Model for Rare Disease Management. We are very curious about this. So the floor is yours.
Hi, everyone. Thank you, Sara, for the presentation. I'm sharing my screen. Okay. Okay, so the objectives of this presentation are to describe our hospital's model for the management of rare and complex diseases and to highlight the importance of communication between different specialists and between patients and clinicians. But why do we need a dedicated model for rare and complex diseases? We know that these diseases encompass a lot of issues in their management, such as their high complexity, their time-consuming diagnosis, the lack of coordination between specialists, often leading to delayed decision-making, and the fragmentation and variability in patients' management, with an high risk of loss to follow-up of our patients. Starting from the beginning of our patient's journey, we know that at the onset of symptoms, the patients usually don't meet a rheumatologist, but more often a general practitioner or other outpatient specialists or hospital specialists. And these figures need to be able to identify red flags for a correct referral, because this can make the difference between early and late diagnosis. So after the suspect of a rheumatologic disease, they have to proceed to the correct referral to a rheumatology clinic. And how do we overcome this problem? We organize within our region regular meetings with general practitioners and regional specialists with the purpose to give input to these professional figures to recognize red flags and to orient patients' correct referral. After the diagnosis, we know that we will need to face with the other specialists included in this complex disease management, such as the psychiatrist, neurologist, dermatologist, cardiologist, nephrologist, hematologist, ophthalmologist, and pneumologist. But how do we communicate effectively with these figures? In our hospital, we built two ways of communications with other specialists. The first one is the creation of multidisciplinary meetings. These are meetings scheduled on a regular basis, weekly or monthly, with the participation of different specialists involved in patient management, and with the presentation and discussion of complex clinical cases, promoting a shared decision-making process. We also exchange our best practices in these meetings and updates on current guidelines. We have these multidisciplinary meetings with pneumologists and radiologists once every 2 weeks, with nephrologists once a month, and hematologists once a month. The second way is through the shared clinics. The patient is visited by 2 different specialists at the same time, promoting a timely diagnosis, a coordinated treatment plan, and ensuring an holistic care. Unfortunately, we have these shared clinics only with nephrologists once a month and dermatologists, but we are trying to implement also this way of multidisciplinary collaboration. And now I want you to present the development of a diagnostic and therapeutic clinical pathway in our hospital. We know that the diagnostic, therapeutic, and clinical pathways are a way through which selected patients can access to dedicated diagnostic and therapeutic procedures through specific referral codes. Who is involved? All healthcare professionals involved in rare and complex disease management, where in all medical units involved within our hospital. And when we selected dedicated time slots in predefined days of the week or of the month for each medical unit. And the referral comes from the hospital inpatient clinic itself, or from general practitioners and territorial specialists through the regional booking system. Who is included in this pathway? Adult patients with confirmed or suspected diagnosis of one of the diseases included in the pathway. Today, our pathway is composed in this way. It includes the systemic lupus erythematosus, the antiphospholipid antibody syndrome, the undifferentiated connective tissue disease, and we are working on the inclusion of Sjogren's syndrome. The medical units involved are the rheumatology, the nephrology, the neurology, both the neurovascular department and the neurologic department, the cardiology, the hematology, the dermatology, the psychiatry, the pneumology, the ophthalmology, the infectious diseases, and the internal medicine. The procedures included are the first visit, the follow-up visit, the performance of autoimmune laboratory tests, the echocardiography and electrocardiography, vascular ultrasound, joint ultrasound, nail fold capillaroscopy, ophthalmologic imaging, neurophysiologic tests, and pulmonary function tests. We have also performance indicators to monitor the activity of our pathway. The first one is the adherence index, the number of patients attending the first visit over patients enrolled in the pathway. The dropout assessment, the number of patients attending follow-up over the number of patients scheduled in the pathway. The timely access to the visit, the number of scheduled visits over the number of requested visits. Pathway effectiveness, the number of etiopathogenetic diagnoses over patients evaluated in 1 year. And most importantly, the quality of service provided, because we administer a patient satisfaction questionnaire to monitor the satisfaction of patients regarding our system. The primary targets of this pathway are to ensure an early and accurate diagnosis, to improve the quality and continuity of clinical care, to provide individualized follow-up plans, to prevent relapses and complications through timely interventions, to enhance patients and caregiver satisfaction, and to promote a cost-effective and efficient care delivery. Last but not least, I want to underline the importance of effective communication between clinicians and patients. We know that an effective communication in this way is useful and is important for patients to make informed decisions, to improve patients' adherence to treatment, to build trust between patients and clinicians, to reduce errors both from the doctor and from the patient, and to enhance patient safety through a correct information about the contraindication of different therapies and the possible complications of their disease. How do we implement this kind of communication? We are still working on that. There are a lot of patient associations. This is the logo of the Lupus Italian Group, which is one of the most active associations in Italy, and it promotes regular, at least annually, meetings between patients and clinicians, and this is important to increase patient awareness, for us to understand patients' needs and perspectives, to encourage patients to share their experience, and to inform and update patients. We, as an hospital, are trying also to include patient partners in our research project to intervene in the methodology of the project, the main outcomes, and to communicate more effectively our results. And these measures are all important to convert patients in therapeutic partners for us. So I showed at the beginning of this presentation all the problems we are facing, but now we can see some solutions for that, such as the early referral through sharing red flags, primary care education, improving the multidisciplinary management, creating dedicated diagnostic and therapeutic pathways, and implementing patient involvement, so we can smooth our path ahead for both us and our patients. Yeah, and I want to thank you for the attention, and I want to thank all the members of my unit which make this possible. Thank you.
Thank you for this presentation. Very nice. I have a comment, if I may. It is perfectly aligned on what we are doing in ReCONNET. As you probably know, the learning path methodology for mapping. Probably you took inspiration from this, and it's very nice that something that we are doing at international level is performed also at local level. So congratulations for this.
Yes, we hope to integrate this with the ERN because we really admirate our example, and we want also to do that through the CPMS. We never used it, but this is something to implement what we want to do locally to an international level, and I hope we will be able to do that. But now we started first with our hospital because it was easier, of course. But we hope we can grow to your international level.
Okay, thank you.
Thank you, Sara. Are there comments or questions? No, but I just have a comment, Sara, always on behalf of the patients. It's quite important to have such a defined pathway inside because when you receive, you know better than me maybe, but when you receive a diagnosis, you are receiving one of the worst thing in the world, and having such a structured pathway that where the patient is led hand by hand is of paramount importance. So please go on this way.
Thank you.
So if there are no comments, I leave the floor to Rosaria Talarico, who will talk about the red flags methodology that has been not developed, or yes, maybe we can say developed, Sara, during the IgG4 red flags project, and will be used also for the systemic sclerosis project. So please give us some info about the methodology.
Thank you, Ilaria. Thank you. Sorry for those who already heard about this, but today we have also people outside of ReCONNET for sharing the experience. So I will give you a very brief summary on what we did on red flags. The next, please. As all of us know, we know that we have also in the different activities of the ERN in general of ReCONNET, of course, clinical practice guidelines. So we have to work on clinical practice guidelines, not in terms of a scientific society, but in terms of adaptation and dissemination of clinical practice guidelines. Next, please. And what we did in the first years of activity of ERN ReCONNET is to work on, first of all, on the adherence of clinical practice guidelines. So we know very well that we have a problem in being adherent to clinical practice guidelines. We checked this and we highlighted that there is a problem for many, many reasons, resources, time, but not in terms of having clinical practice guidelines. Next, please. In our field of rare connective tissue disease, actually we have a lot of clinical practice guidelines, and what we also did is try to perform a state of the art on what we have, and we, as the majority of us know, we published this in a supplement dedicated to the state of the art of all the clinical practice guidelines that we already have for our disease, provided in majority of cases from the International Scientific Society. Next, please. What we already did is try to disseminate the clinical practice guidelines, since the mission, one of the mission of ERN is try to share the knowledge, but also disseminate what we already have. And one of our objective is disseminate what we have in terms of clinical practice guidelines. Next, please. But also try to make the information in a lay version. So we produced also with the big support of our ePAGs, a lay version for clinical practice guidelines, and also education resources for patients in terms of what we need to know for clinical practice guidelines, how to use these tools, these instruments. Next, please. And the lay version coordinated by Ilaria for systemic sclerosis, together with the disease coordinator for systemic sclerosis, and the lay version is published on the website. Next, please. But we thought that there is something lacking in this pathway of clinical practice guidelines, and we decided to work on the section of this journey regarding the primary care GP. So we decided also, the next please, also thanks to the support of the European Commission, they provided to all the 24 ERNs the possibility to work with a contractor, a team of methodologists, and we decided together in the framework of the working group research and clinical practice guidelines to use this work for providing not a new clinical practice guidelines, but to produce a red flag for GP or for primary care to reduce the delay in diagnosis. We know very well that is a big issue that we have, and the target audience for different stakeholders. And we also included the president of the European Society of GP. This is very important. For what? For signs and symptoms for an early diagnosis. Next, please. And what we did is use the work of this contractor, Aragon Health Science Institute. Next, please. And work together with them. We decided to identify as first case of development of red flags the IgG4 related disease. That is one of the diseases covered by ERN, but also is one of the complex disease with a very variable phenotype. And it is really, really important in all the disease covered by the ERN, but mostly for the more complex disease, try to define signs and symptoms for red flags. Next, please. So what we try to do is explore these signs and symptoms in order to encourage and facilitate an early referral, not an early diagnosis, but an early referral for the center with an expertise for IgG4. And we did this combining, this is the methodology we used, combining the evidence with the eminence, combining the systematic literature review results and data with the expert opinion, since in the framework of ReCONNET, by definition, we have expert clinician and expert patient. Next, please. So what we did is try to translate this research question, which signs and symptoms are specific for an early recognition of IgG4, and we translated this in a PICO version, that is the modality of translating a research question in something that can be searchable in the literature. Next, please. And we found a lot of data regarding signs and symptoms, but we combined this with the expert opinion, and we tried to identify a small number of signs and symptoms. These red flags means something very short, very simple to be used in primary care. And we used the methodology that is the standard methodology for provide recommendation of red flags and agreement. Next, please. And by means of this methodology, we developed the first red flags in the framework of ReCONNET, the red flags for an early identification of IgG4-related disease, as you can see published on Lancet Rheumatology. And it is a very important paper in terms also of dissemination, since a lot of people use these. Also the table next, please, with the specific red flags, since it is important not as a paper per se, but as the dissemination of something very useful in the real life. So signs and symptoms that for primary care, for GP, but also for not expert specialists can be useful to focus the attention on an early referral for these really complex patients. Next, please. And you can see in these slides the overview of the methodology, starting from the evidence, moving to the eminence and propose red flags by means of an agreement, of course, publication, since we needed to disseminate them. Next, please. Okay, I'm not sure it was another slides, but the main message is that we need, and it is very curious that this presentation is after other presentation talking also about the journey and the pathway, since it is important to share the knowledge regarding the diagnosis, but it's really important to create something that can facilitate the referral to the patient of the patient to the centers specialized for a disease. So we are using this methodology for myositis. We are finalizing the red flags for myositis, and we are using also this approach to create other red flags. For example, red flags not for early diagnosis, but for an early recognition of patients that need to be referred to excellent centers, for example, for biologic therapy or for other therapy in systemic sclerosis. So it's really important to have red flags for facilitate the big delay in diagnosis that we know is a very big problem in rare and complex connective tissue disease. Thank you.
Thanks to you, Sarah. And it's true, our biggest enemy that must be fought is time and delay in the diagnosis or organ involvement. So red flags are very, very important. So questions, comments?
If there are no comments, probably we can move to the last presentation. A presentation from Zoe. Your surname is very difficult for me. Zarakikla Mitsaku, okay, the General Secretary of Lupus Europe. And it's a pleasure for us to hear about a very important good practice regarding lupus GBT. Please, Zoe.
Hello, thank you. So Anne-Marie, who is from our team, will share the slides. Thank you, Anne-Marie. So I'll just wait for the deck to be live. There we go. Wonderful. Thank you, Anne-Marie. So, hello, I'm Zoe from Lupus Europe. As you said, I'm here to talk about Lupus GPT today, and I'm very, very excited to do that. Thank you so much for the invitation on that. So, to start really on this, let's talk a little bit about what the issue is. So, you all know RMD patients regularly search for information about their disease online. You all know the quality of information on rare diseases, on RMDs, on lupus, on the internet, a real issue. But patient education is key really to the self-management of chronic diseases. And an essential component of patient education is, of course, access to valid information. So our experience in Lupus Europe is that many patients in Europe cannot access information on their condition in English due to language barriers. But in any information for patients, the language used must also be patient-focused. It doesn't matter doesn't only matter what language it's in, it has to be patient-focused. And to address that, patient-doctor collaboration is key. Next slide, please, Anne-Marie. So in 2024, Lupus Europe ran a pan-European survey on different aspects of living with lupus. More than 4,500 patients across Europe answered that survey. So one of the things that was concretely discovered in that survey is that patients don't wait for their next specialist appointment to raise any questions they have. 45.3% of respondents to the survey said they use social media at least weekly to get answers to their lupus questions, with 27.3% using Google regularly for that purpose. Now, people don't get to see their lupus specialist that often, of course, so they turn to the internet for answers to their questions. But what that survey also told us is that despite the fact that so many people use Google or social media for their lupus questions, the trust level they themselves have in the quality of that information they get is almost the reverse to their use. So patients recognize really that social media can't be trusted for health information, and that Dr. Google is a really, really, really horrible doctor, but they go there anyway. So if we go to the next slide, in 2018, this really huge project started, which was Lupus 100. And the Lupus 100 project was created really in an effort to tackle all of these problems around valid information and using the internet to fight misinformation. Well, the objective of this project was to provide access to quality information on lupus online by answering 100 common questions patients have about lupus in the native languages of more than 95% of the European population. It launched with one language in 2022, this project, and since then, 25 translations across European languages have been completed, many of them under final validation. 19 different languages are online at the moment, and we're covering about 87% of the native languages of the European population. This project, Lupus 100, has been huge work. Doctors and patients have come together for this project to create the English version of Lupus 100, but then doctor and patient teams around Europe were created, and they worked together to produce each language translation version to validate it. But to actually validate translations for Lupus 100 across 19 languages, it has taken an incredible amount of work, an incredible amount of volunteering hours for patients and doctors to review translations, to validate them. It's been really painstaking. But then we came to the European Lupus meeting and to March 2024, where there was a fishbowl session in which patients and doctors came together to talk about artificial intelligence and this issue of Dr. Google. And at that fishbowl, this idea was born of, what if we took ChatGPT? We put it in a room with no doors, no windows, no way to get out, and then put in that room only documents on lupus that patients and doctors jointly selected as being very, very high quality, and then asked the artificial intelligence tool to answer any question patients might have on lupus in a patient-friendly language. So I have to say, I can't say this enough, that Lupus GPT, although it is a tech project, it didn't start as a tech project. It started as a dream, but also a dialogue between doctors and patients. And I think the reason I mentioned that, and that it's really, really important to mention, is that doctor-patient dialogue has colored the project throughout. If we can go to the next slide, please. So what is Lupus GPT tangibly? So Lupus GPT is an artificial intelligence tool. It can answer questions about lupus in almost any language. It uses only valid medical resources like Lupus 100, like the EULAR updated guidelines for lupus. And to make this really simple, what we did was exactly what I said before, what we dreamed of. We built a room, we put this tool inside the room, and we close the door. We lock the door, it can't escape, it cannot use any sources of information other than the ones we give it to answer questions on lupus, and that makes it a dynamic source of information on lupus in almost any language. This is a tool people can go to ask their own questions in their own words and to get a medically valid answer in lay language in dialogue format. It isn't static, because most sources of information on health online, they're static, and it isn't this sort of complicated medical language like medical journal articles that are incredibly useful, incredibly valid, but very, very hard for patients to access who are lay patients. This is tailored to be patient-friendly in language. So we've got Lupus GPT that does all this, but we also developed a feature within Lupus GPT called Easy Lupus, which is a feature that uses the exact same library of valid documents Lupus GPT does, but it gives answers in much simpler language to about a level of a 10-year-old child. And the aim of that is to broaden information accessibility on lupus for people who have lower literacy. And we've made both Lupus GPT and Easy Lupus deliberately open. There's no login, there's no paywall, there's no subscription. You can just scan the QR code and go to the web page and just try it. It's housed on a completely open page. Now, if we could go to the next slide, please. Lupus GPT launched in 2024, since its launch in September 2024, it's answered more than 60,000 questions across 124 countries. Now, the organization is Lupus Europe, so the organization focus is on lupus and on Europe. But we have been so happy to see that from those 124 countries that have used Lupus GPT, 39 of them are low and middle income countries, which is, we think, is a really, really powerful statement. We think access to valid health information on chronic diseases like lupus, it's a global need, and that really shows that. Obviously, for us, part of the real success of Lupus GPT is in something very, very different as well. It's when we're at a congress or when we get an email from a doctor that says, actually, there was nothing on lupus in my language, in my country to give my patients. This is finally something I can give my patients. And this happens more and more. And this feedback anchors us to the purpose of the tool, reminds us why tools like Lupus GPT are important. Now, if we go to the next slide, Lupus GPT is obviously lupus specific. Now, it's lupus specific in that the library of documents that's behind it and the information that it then gives because of that library of documents is lupus specific. But really the blueprint of it, the model of it, the way of collaborating, none of that is lupus specific. And in fact, Lupus GPT is something that can be replicated across ReCONNET disease areas. Now, we've thought a lot about this, and to replicate Lupus GPT for another disease area, there is a really simple blueprint, and the very first step is to either create or identify reliable core content for a document library. Now, that content has to be medically sound, but it also must be shaped by what patients actually need, and that's really key. So when building a Lupus GPT, we had Lupus 100, and that was an incredible asset. But even if an equivalent to Lupus 100 doesn't exist for another disease area, there might be clinically relevant, clinically valid documents that answers patients' basic questions, or it might be that they need to be created. But this is really the starting point. It's a document library. Then we've got patient-doctor collaboration, which is really, really a non-negotiable, and it's essential at every single stage. It's in co-writing, co-validating, co-testing the tool, and co-refining. That's what gives a tool like Lupus GPT both medical accuracy, but relevance for patients as well. And I have to say here, to take a second and say that the work that the ReCONNET SLE working group of doctors across Europe have done for Lupus GPT, together with patients on testing the tool, it's been really, really humbling to see. We're very, very grateful for the time and care every single specialist has given so graciously to help ensure that this tool works optimally for patients. And really, really, really humbling. Now, AI technology, obviously in Lupus GPT, AI technology powers the tool itself. We have a way that we've done that for Lupus GPT. We're more than happy to openly share that way, the steps, the learnings with other disease areas, other organizations. There are also other ways to do this. There's a number of ways that somebody can lock a room and a number of large language models that people can do this with. And AI technology is certainly developing incredibly quickly. Accessibility is a very, very key point. So we thought big with Lupus GPT, thought multilingual, culturally sensitive, but also easy to read formats. There's a lot that everyone can do to ensure that no one is left behind. Valid information is important for everyone. A key learning for us on this is that there's always, always more that we can do to broaden accessibility and work to get valid information to the hands of even more people. So at the moment, we're testing a voice-activated version of Easy Lupus. So people can go on the website, say their question to the AI instead of write it, and then get a spoken answer back. This is in beta at the moment and evolving as we speak. And this might be one of the ways that people can get valid information on their disease, even if they're illiterate. Now, this cannot be said enough, this last point, no one should wait for perfection. So launching early, gathering feedback, refining, iterating, getting usage data, using it very strategically, embedding feedback loops in a project to measure what's working, fixing what isn't, listening to the community's needs and using that to improve. Those are some of the elements that make a project like this work. It's not perfection, but in very, very broad strokes, that's the blueprint. If we could go to the next slide. So taking action. So as I said, any disease area can replicate Lupus GPT. So we can have many, many tools, multilingual, free, accessible for people giving valid information. So this is a replicable model across all ReCONNET disease areas. But as I said before, this version of Lupus GPT for a particular disease area, it begins long before artificial intelligence comes into play. It really starts with building a library of documents around that disease. And that's what allows people to start and scale up, to refine the core content, to expand. Very, very importantly, no one can do this alone. Collaboration is key in projects like this. Collaboration, when I say collaboration, I mean collaboration across patient organizations, across disease areas, across disciplines for projects like this. And when we share knowledge with each other, it's a way to amplify our impact, which is collective, really, and fighting misinformation, which is a common goal. So if we could go to the next slide. So thank you. We really love sharing these best practices, and really we're trying to share this even broader. So we have a webinar on this, and of course we will highlight ERN ReCONNET at this webinar as well. So you can register just by sending an email. And really that's all. Thank you so much for inviting us here to talk about this. We're very excited and very excited to answer any questions.
Thank you, Zoe. Really, really interesting. Always on behalf of patients. You are fighting disinformation and misinformation, which are really crucial today. It's a really interesting project. Thank you.
I would like to add, it is indeed something that can be done for all the diseases. So as we have done in ReCONNET, I mean, the red flags for IgG4 were nothing but a pilot project, and the RN path for systemic sclerosis and lupus GPT. I think this is really what we are here for, to spread good ideas and inspire the different disease groups and find funding to do that as well, I think.
Yes,
because we need a
absolutely.
little money to do this, but then you can suggest us how to move on. And so that, I mean, this is really great. I can tell you that I advise my patient to go and to read on lupus GPT, and as well as 100 questions, and it is very useful, really.
Wonderful.
So thank you very much.
Thank you.
Are there comments or questions? No, just congratulations. It's an amazing work.
Thank you. Okay, and if anybody has any questions after this, just send us an email. Always happy to answer.
Yeah, Zoe, was very expensive, this project, because, you know, when you want patient organizations to develop a thing like this, the question mark is always, where do I find the money?
That's a really valid question. Thank you for asking that. I will say, compared to Lupus 100, which was a giant project, this is a fraction of that. But also because Lupus GPT was the first time that this was done. For us, it was more expensive to do that a year ago than it will be for any organization now, because actually the path is there. So I think we've asked for quotes to understand a little bit the cost for subsequent sort of patient organizations or anyone who might like to do that. And it is about a 20th of the cost that it was last year. And this also helps with AI technology evolving. These things are getting cheaper and cheaper. So I think it's one of the most approachable financially options for patient organizations. It's certainly nothing compared to a website like Lupus 100, where you've got to make everything pretty and include the design and the landing pages in all languages and publishing rights, etc., all of which carry a heavy burden of cost. Yeah. So,
and are you going to make other translations in other languages?
For Lupus GPT?
Yeah.
So Lupus GPT, and thank you for letting me highlight this, Lupus GPT speaks almost any language really on its own. So this is one of the incredible positives compared to Lupus 100, that nobody needs to make the translation. It will automatically do it using really technology. So what we have had to do very, very carefully is validate that it actually works across languages, across European languages. Okay, so to do that, we've come to the SLE working group of ReCONNET, to the doctors. We've gone across national groups in Europe to patients, and we've asked people to ask it 3 to 5 questions that patients commonly raised, and to give us feedback, really. Does it work okay in your language, in Italian, in Spanish, in Portuguese? And then from that feedback, we've iterated and improved, because it did need tweaks, really, across many languages initially. And when we do an upgrade in the model, or when we change something in the back end of the GPT, sort of in the library of documents, we retest again. Not because we think anything happens, but just to be safe and as a good practice, really. But we don't need to manually translate. And I think that's one of the incredible benefits, and where we get information from doctors coming up to us and saying, my goodness, my patients, they speak Tagalog. I had nothing in Tagalog. And now this speaks Tagalog. We didn't program it to speak Tagalog, right? It does that by itself from the technology that it
Okay.
has. So this is very, very good. And minority languages.
Good question.
Thank you.
Thank you.
Thank you, Joy. If there are, I see an hand raised. Alvaro Gomez, please.
May I also ask something? Hi, this morning I work in Sweden, and I was in a meeting here in Sweden. So there's an initiative where patients are demanding some more sources of information. And what this group has decided is to create an app where lots of information are going to be collected, so entered by patients themselves as a sort of means of monitor themselves. But it's been this need of having a chatbot. So then it may be a bit of a technical question here, but do you think this platform you've created is transferable to an app, or is the only way to access it through the web page?
So for this particular platform, the only way to access it is through a web page. So if you replicate, you would replicate into a web page. But there are a number of app-based AI sort of platforms that you can use quite low cost to do something like that. If you send me a message afterwards, I can tell you. Yeah.
Will do. Thank you.
Thank you.
Thank you. Thank you. So we have a few minutes of delay, but it was a so interesting meeting. So thank you to all of you. As usual, Monica is asking for turn on your webcam if you can, so we can catch a picture and share on our social media. So a few seconds more. Turn on your webcam. Okay.
Cheese.
No, let's say ReCONNET.
ReCONNET.
It's okay, Monica? Okay.
Okay, thank you.
Okay. So thank you to all of you.
Thank you very much.
Thank you. If we don't have another case.
Thank you. Have a good evening.